Hello friends, welcome back to my channel. This video is my 20th notebook of pathology subject for Neet PG exam. Let's start with gastrointestinal stromal tumor. GIST or gastrointestinal stromal tumor is the most common mesenchymal tumor of abdomen. Most common benign tumor of esophagus is leiomyoma. Site of extranodal lymphoma is stomach. Maximum duration of TRALI, that is transfusion related acute lung injury, to occur after blood transfusion is 6 hours. Lymph node biopsy of measles shows Warthin-Finkelty giant cells. Extragonadal germ cell tumor, most common site is mediastinum. Other sites are retroperitoneum, pineal gland as well as sacrococcygeal area. Miliary TB shows 2 mm small foci of yellow-white consolidation. Miliary TB spread is by hematogenous route. Montague's test is negative in miliary TB. Gastric adenocarcinoma is an epithelial tumor of stomach. Bernard-Solier syndrome is an autosomal recessive condition. Here bleeding time is prolonged. In Bernard-Solier syndrome, there is an absence of GP1B95 receptor. Glanzmann's thrombasthenia is an autosomal recessive condition. Here bleeding time is prolonged. There is an absence of GP2B3A receptor. Single most important long-term limitation of cardiac transplantation is allograft arteriopathy. Cellular rejection is interstitial lymphocytic inflammation associated myocyte damage. Prolonged bleeding time is seen in von Willebrand's disease. Type 1 Willebrand's disease is an autosomal dominant condition. Here BT is prolonged. Platelet adhesion defect is seen in type 1 von Willebrand disease. Myotonic dystrophy affects chromosome 19. Cowden syndrome is mutation in P10. Mutation in KIT. Mutation in KIT is seen in GIST. GIST is gastrointestinal stromal tumor. Mutation in KIT is seen in GIST. Mutation in KRAS is seen in colon carcinoma. Mutation in ABL is seen in CML. Mutation in beta-catenin is seen in hepatocellular carcinoma. Mutation in PDGF is seen in astrocytoma. Stellate granuloma is seen in cat scratch disease, which is also known as subacute regional lymphadenitis caused by Bartonella Hensley. Dirk's granuloma is seen in cerebral malaria. Caseating granuloma is present in TB, syphilis, histoplasmosis as well as coccidiomycosis. Non-caseating granuloma is seen in Hodgkin's lymphoma, Crohn's disease, leprosy, sarcoidosis. Mutation in SMAD is seen in pancreatic carcinoma. Mutation in P53 is seen in Lee-Fromany syndrome. Most common cause of agranulocytosis is drug toxicity. Causes of agranulocytosis include ineffective granulopoiesis by inhibition of hematopoietic stem cells in aplastic anemia, ineffective hematopoiesis in megaloblastic anemia as well as myelodysplastic syndrome, congenital conditions like Costman syndrome. Increased destruction or sequestration of neutrophil is seen in congenital condition, that is Costman syndrome. Increased destruction or sequestration of neutrophil is seen in Costman syndrome. In SLE as well as splenomegaly, we can see agranulocytosis. Opsonin is present in C3b, C4b, C5b, CRP, fibrinogen, mannose binding lectin, IgM receptor of IgG as well as FC receptor of IgG. C3A, C4A, C5A, all these are anaphylatoxins. C5A is a chemotactic agent. CD59 is mainly seen in paroxysmal nocturnal hemoglobinuria. PNH clinical feature is cola colored urine, pancytopenia, hypercellular bone marrow, thrombosis of the hepatic vein which causes Budd-Chiari syndrome. Diagnosis of PNH is Ham's test, that is, it shows acidified serum lysis. Next is sucrose lysis test, and the other diagnosis method is flow cytometry, which shows inhibition of CD59 and inhibition of CD55 on RBC. L and H type RS cell, these are seen in lymphocyte predominant Hodgkin's lymphoma. Consistent and persistent feature of bladder carcinoma is painless hematuria. Fever during inflammation is due to interleukin 1 prostaglandin as well as TNF. Histamine is a mediation of vascular events of inflammation. Anaplasia is lack of differentiation. Anaplasia is the important morphological feature of malignant transformation. Telomerase theory of aging shows decreased telomere length which is associated with aging. Leiden mutation is associated with factor 5. Single nucleotide mutation is associated with factor 5. Most important malignant potential in papillary size of renal tumor is size. Papillary type of renal tumor consists of renal papillary adenoma less than or equal to 1.5 cm and papillary type of renal cell carcinoma more than 1.5 cm. Papillary renal cell carcinoma shows foamy macrophages as well as psammoma bodies. A child with recurrent chest infections and abdominal pain had history of one blood transfusion in the past. Child also had icterus, mild splenomegaly. There is increased HbA2, HbF and S spike. Diagnosis is sickle cell disease. It is an autosomal recessive condition. In sickle cell disease, on microscopy we can see sickle-shaped RBCs as well as polymerization of deoxyhemoglobin. Point mutation of beta globin gene is associated with the replacement of glutamate with valine. Clinical features of sickle cell disease include moderately severe hemolytic anemia with jaundice, painful bone crisis, acute chest syndrome with pulmonary infiltrates, aplastic crisis which is caused by parvovirus B19, leg ulcers, stroke, priapism, crew-cut skull. Diagnosis shows increased HbA2, increased HbF, increased S spike. Acute coronary syndrome is associated with Kawasaki disease. Treatment for Kawasaki disease is IV immunoglobulin plus aspirin. Beta thalassemia is an autosomal dominant condition. There is increased HbF, increased HbA2. In beta thalassemia, there is mutation in alpha or beta globin which reduce hemoglobin synthesis. Neoplastic cells utilize Warburg metabolism. It forms metabolic intermediates needed for cell growth and multiplication. Increase in glucose produces lactate and oxygen. HBC disease causes increased HBC level. There is mutation in beta globin chain. Glutamate is replaced by lysine in HBC disease. Glutamate is replaced by lysine in the 6th position of beta globin chain. An elderly patient with anemia and hemoglobinuria due to intravascular hemolysis. There is increased LDH. Peripheral smear showed schistocytes. Diagnosis is macroangiopathic hemolytic anemia. Presence of mechanical second heart sound can be heard here. Neutrophil extracellular trapping, that is NET, mitochondrial DNA is not seen. Neutrophil extracellular trapping is seen in blood during sepsis. It is seen in bacterial infection. Chromatin with antibacterial enzymes are present. Michaelis-Guttman bodies stain is von Cosa stain. Here we can see calcium along with iron. Warburg effect is growth factor receptors downstream signaling pathways which include receptor tyrosine kinase P13K, AKT, and MYC. A patient on cystoscopy showed multiple yellow-white plaques in the trigone of bladder. Histopathology, they were Michaelis-Guttman bodies. Diagnosis is malakoplakia. Here we can see Michaelis-Guttman bodies by using von Cosa stain. These are soft plaques. Malakoplakia means there is defect in phagocyte function. E. coli or Proteus are the organisms causing this. It is mainly seen in patients, that means immunosuppressed patients like renal transplant patients. In histopathology, we can see foamy macrophages with granular cytoplasm due to phagosomes. Next is polypoid cystitis. It is seen in patients with indwelling catheters. H&E stain shows broad polypoid growth, prominent blood vessels and metaplastic urothelium. Ferruginous bodies are seen in asbestosis. Hirano bodies are seen in Alzheimer's disease. Verroki body is seen in schwannoma. Donovan body is seen in Granuloma inguinale. Councilman body is seen in acute viral hepatitis. Hin's body is seen in glucose 6-phosphate deficiency. Civete body or colloid body is seen in lichen planus. Kohl-Exner body is seen in granulosa cell tumor of ovary. Russell body is seen in multiple myeloma. Aschoff body is seen in rheumatic fever. Henderson-Patterson body is seen in molluscum contagiosum. Decreased calorie intake is 30%, which increases the lifespan. Interstitial cystitis is also known as chronic pelvic pain syndrome. Hunner's ulcers microscopy features are there is increase in mast cells in submucosa. Biopsy is done to rule out carcinoma in situ. Next is ARDS, acute respiratory distress disease. There are 3 phases: exudative phase, proliferative phase as well as fibrotic phase. A patient who had COVID-19, patient's age is 56-year-old patient, he was on mechanical ventilation, passed away after a week. COVID-19 patient, he was affected by SARS-CoV-2. Patient had acute respiratory distress syndrome. Postmortem change in lungs showed thick layer of fibrin or waxy hyaline membrane lining alveolar wall. ARDS has 3 phases. Exudative phase, that means there is 7 days of illness. It consists of type 1 pneumocytes. Second phase is proliferative phase. The patient has this condition from day 7 to 21. Recovery from mechanical ventilation. Third is fibrotic phase. There is extensive alveolar duct interstitial fibrosis. Now, what is Berlin's definition of ARDS? That means chest X-ray shows bilateral opacities, respiratory failure within 1 week of alveolar insult. There is decreased PaO2 or FiO2 ratio to less than 300. Symptoms of respiratory failure are not due to heart failure or fluid overload. Diagnosis of COVID-19 is by nucleic acid amplification testing of respiratory tract secretions by nasopharyngeal swab. There will be increased interleukin 6, increased TNF, increased ferritin, increased CRP, increased D-dimer, increased lactate dehydrogenase. Menser index is MCV count by RBC count. A female patient who had fatigue, hemoglobin was 9 gram per deciliter, that means hemoglobin is reduced. MCV is 60 picoliter, that means MCV is reduced. RBC was 5.2 million, that means it is normal to increased level. Peripheral smear showed microcytic hypochromic anemia. Diagnosis is thalassemia. HbA2 levels should be monitored. By Menser index, we should examine which is the diagnosis. Menser index is MCV count by RBC count. If Menser index is less than 13, it is thalassemia, and if Menzer index is more than 13, it is iron deficiency anemia. Here in this case, MCV is reduced, hemoglobin is reduced, and treatment of thalassemia is blood transfusion every 2 to 4 weeks, chelation therapy with deferoxamine, deferazerose, deferiprone for iron chelation, splenectomy, HSCT, that is hematopoietic stem cell transplantation, which is only curative treatment for thalassemia. Serum homocysteine levels are increased in vitamin B12 deficient macrocytic anemia. In iron deficiency anemia, iron will be less than 60, ferritin will be less than 20, total iron binding capacity will be increased, transferrin will be decreased less than 15%, MCV is reduced, RBC is reduced. In alpha or beta thalassemia, iron will be normal or increased, ferritin will be normal or increased, TIBC is normal, transferrin is normal, MCV is decreased, RBC is normal or increased. In anemia of chronic disease, iron will be reduced, ferritin is increased, TIBC is decreased, transferrin is normal or decreased, MCV is normal or decreased, RBC is normal or increased. So, here in all these deficiencies, we should only know about the iron, ferritin as well as TIBC. I'll say it again. In iron deficiency anemia, iron will be reduced, ferritin will be reduced, TIBC is increased. In alpha or beta thalassemia, iron is normal or increased, ferritin is normal or increased, TIBC is normal. Anemia of chronic disease, iron is reduced, ferritin is increased, TIBC is reduced. Next case is 56-year-old male patient had dragging pain in the abdomen, massive splenomegaly. On doing peripheral smear, leukocytosis was present, increased myelocytes, increased metamyelocyte, increased basophils. T922 translocation was seen. This diagnosis is CML. ABL BCR 922 chromosome is present. There is fusion gene translocation mutation. Think about the Philadelphia chromosome. Next is there is exceeding 1 lakh cells per millimeter cube, that is there is leukocytosis. Blast will be less than 10% of circulating cells. Platelet count will be increased. Leukocyte alkaline phosphatase LAP score will be reduced. As investigation, we should do FISH or PCR. CML, we should do Sokel scoring. Treatment is tyrosine kinase inhibitors like imatinib, nilotinib, dasatinib, bosutinib, ponatinib. These all are the treatment of CML. Burkitt lymphoma, we can see starry sky pattern. T1517 is seen in acute promyelocytic leukemia. There is presence of ore rods. Treatment of acute promyelocytic leukemia is all transretinoic acid. According to Mendelian mode of inheritance, about 2/3 of the Mendelian disease are autosomal dominant. Next is a case. Patient had a large retroperitoneal hemorrhage. On strenuous exercise, there is history of intermittent swelling of knees. No history of mucosal bleed. Diagnosis is hemophilia A. There is defect of clotting factor 8 and 9. Intramuscular hematomas, hemarthrosis and hematuria is seen in this patient. Factor 8 is reduced. PTT is prolonged. Treatment of hemophilia includes desmopressin acetate, replacement of deficient clotting factors as well as monoclonal antibiotics like emicizumab. A male patient who is a smoker, who has chronic cough, there was weight loss, fatigue, serum calcium was increased, that mainly represents paraneoplastic syndrome. On lung biopsy, there was large atypical cells with hyperchromasia. Diagnosis is Squamous cell carcinoma of lung, which shows keratin pearls as well as intercellular bridges. Next is a male patient who had increased lymphocytes, increased leukocytosis. On peripheral smear there was smudged cells, generalized lymphadenopathy, hepatosplenomegaly was present. Case is CLL. There was peripheral B cell neoplasm. There is deletion of 13q, which is the most common feature. Diagnosis is CLL. Investigation is flow cytometry. Treatment is fludarabine, cyclophosphamide as well as rituximab. Complication of CLL is Richter syndrome, diffuse large B cell lymphoma. Next is a patient who is a chronic smoker working in a cement factory for 20 years. Patient has mesothelioma. This is a condition called asbestosis that causes lung cancer, mesothelioma. There is diffuse parenchymal interstitial fibrosis. In asbestosis, there is silicate inhalation which consists of serpentine as well as amphibole. In histopathologic evaluation, we can see asbestos bodies. Anthracosis or coal workers' pneumoconiosis is seen in coal miners. There is progressive massive fibrosis. Coal-laden macrophages are seen here. Next is Bagasus. Bagasosis is a patient who has acute diffuse bronchiolitis, diffuse fibrosis, emphysema, bronchiectasis, fever as well as hemoptysis. It is due to inhalation of sugarcane residue. Next case is 25-year-old male patient has decreased hemoglobin, platelet count is 25,000, gum bleeding is present, there is increased PT and APTT. Ore rods are seen here in the cytoplasm of progranulocytes. Diagnosis is AML that results in the formation of fusion gene called PML-RARA. It affects the chromosome T1517. DIC has an increased chance in AML. Treatment of AML is all trans-retinoic acid. Next is silicosis. It is seen in persons working in rock mine or sandblasting companies. Histopathological evaluation is there is coalescent nodules of whorled collagen fibers. Eggshell calcification of lymph node is seen in silicosis. Next is a case of Burkitt's lymphoma, that is an African child who has a mass in the jaw. On biopsy, there was starry sky pattern. There is translocation of T814. It is Burkitt's lymphoma. The B cell non-Hodgkin's lymphoma translocation of c-Myc gene on chromosome 8 is present. There is increased MYC protein level. Multiple myeloma shows flame cells, mode cells, Russell body or Dutcher bodies. Next case is a child had intermittent jaundice, splenomegaly, history of same in the brother, peripheral smear showed spherocytes, spherical RBC without central pallor was seen. Diagnosis is hereditary spherocytosis. Investigation is osmotic fragility test. Hereditary hemolytic anemia was present here. Hereditary spherocytosis is an autosomal dominant condition. There is mutation in ankyrin, band 3, spectrin as well as band 4.2. Subendothelial deposits are seen in membranoproliferative glomerulonephritis type 1. Crescentric glomerulonephritis is also known as rapidly progressive glomerulonephritis. Mesangial deposit is seen in IgA nephropathy. Next is a case, a child had cola-colored urine, hypertension, puffiness of eyes, creatinine was 2.5 mg per deciliter. After the next 3 weeks, there was no improvement in creatinine value. Creatinine value increased to 4.5 mg per deciliter. On electron microscopy, it was subepithelial deposits or subepithelial humps. Diagnosis is post-streptococcal glomerulonephritis, progressing to rapidly progressive glomerulonephritis. IgG granular deposits were seen. Complement C3 along with glomerular basement membrane in mesangiomes were seen. On histopathological evaluation, crescent formation was present. Post-streptococcal glomerulonephritis is caused by group A beta hemolytic streptococci. Each patient was given 4 units of blood. He was given blood transfusion. He had chest discomfort. On X-ray, it showed bilateral fissural thickening. Most common cause is fluid overload, that is transfusion associated circulatory overload, that is TACO. Treatment is stopping the transfusion and administering oxygen and diuretics. Next is a 48-year-old male patient had facial puffiness, frothy urine, hypertension, hepatitis B infection. Urine showed microscopic hematuria. On histopathological evaluation of kidney, there was spike and dome pattern in silver staining, which was shown on light microscopy. Diagnosis is membranous nephropathy. Most common cause of nephrotic syndrome is membranous nephropathy, which is seen in the age group 30 to 50 years. Immunofluorescent microscopy, we can see IgG4. Autoantibodies against the renal antigen phospholipase A2 receptor is present in membranous nephropathy. Autoantibodies absent in secondary membrane nephropathy causes captopril, NSAIDs, penicillin, hepatitis B, hepatitis C, syphilis, malaria, malignancy of lung, malignancy of colon, SLE, Sjogren's syndrome. On electron microscope, subepithelial deposits or epimembranous spikes and effacement of food process of podocytes were seen. Treatment of membranous nephropathy include immunosuppressive drugs like steroids, cyclophosphamide, chlorambucil, mycophenolate, mofetil. Next case is 5-year-old child had fever, chest pain, fatigue, cardiogenic shock, left ventricular dysfunction. Endomyocardial biopsy, which is the gold standard investigation, showed lymphocytic infiltration. Diagnosis is lymphocytic myocarditis. Most common infectious myocarditis is caused by the viruses. Next is plasma cells, Anishko cells, Aschoff bodies. These all are seen in acute rheumatic fever. Chagas disease shows amastigote within myocyte. Minimal change disease shows normal glomeruli. There is no Ig deposits. Diffuse effacement of food process of visceral epithelial cells, which is also known as podocytopathy, is seen in minimal change disease. Focal segmental glomerulosclerosis is the most common nephrotic syndrome in adults. There is hyalinosis and sclerosis of capillary wall. Lipid droplets and foam cells are present in sclerosed area. Fragile X syndrome shows mental retardation, macroorchidism, large everted ears. There is CGG sequence, that is trinucleotide mutation of FMR1 gene in the long arm of X chromosome. Secondary osteoblastic is seen in prostate cancer. Punched out ulcer in esophagus is caused by HSV. Herpes simplex virus esophagitis is seen in immunocompromised patients. Biopsy from edge of ulcer is due to eosinophilic type A cowrie inclusions. Alpha-1 antitrypsin, there is absence of elastase. Alpha-1 antitrypsin deficiency, there is mutation of SERPINA1 gene in the long arm of chromosome 14. 55-year-old male patient had hepatomegaly, dark tan, avoiding sun exposure. Diagnosis is hemochromatosis. On microscopy, there is hepatocellular iron which stains blue with Pearl's Prussian blue stain. Iron in the liver normal is 2 to 6 gram, but in hemochromatosis, iron in the liver is more than 50 gram. Triad of hemochromatosis is micronodular cirrhosis, diabetes mellitus, as well as bronzing of skin. In Barrett's esophagus, there is squamous esophageal epithelium with goblet cells. There is intestinal metaplasia. Barrett's esophagus increases the risk of esophageal adenocarcinoma. treatment of Barrett's esophagus is settle protocol. Alzheimer's disease is associated with Down syndrome. Interleukin 1 is activated by caspase 1. Interleukin 1 is involved in pyroptosis. Anti-apoptotic factor is seen in BCL2. Apolipoprotein E4 has risk factor for Alzheimer's disease. It shows mini mental status examination less than 24. Modified Duke's criteria includes single positive blood culture for Coxella burnetii, which is a major criterion. Interleukin 1 is endogenous pyrogen. Endogenous pyrogen include interleukin 1, TNF as well as prostaglandins. Vessel wall of patient with polyarthritis nodosa. Necrosis type is fibrinoid necrosis. It is seen in SLE, Lippmann-Sachs endocarditis, Arthus reaction, serum sickness, post-streptococcal glomerulonephritis, PAN, malignant hypertension. Alzheimer's disease treatment is NMDA antagonist, that is memantine, cholinesterase inhibitor, that is donepezil, galantamine and rivastigmine, monoclonal antibody which inhibits N-terminus of A-beta peptide, that is aducanumab. Alcohol abuse affects the development of dilated cardiomyopathy. Follicular lymphoma is associated with overexpression of BCL2. Here the chromosome is 14-18 translocation. 65-year-old male patient. Clinical examination was normal, urine examination was normal, hematological examination was normal. X-ray skull was done. It showed solitary punched out lesion without a sclerotic rim with beveled edge. Diagnosis is Langerhans cell histiocytosis. 47-year-old female patient who has rheumatic heart disease. Patient had severe breathlessness. On day 3, patient died. On autopsy, mitral valve showed fish mouth or buttonhole appearance due to calcification as well as fibrosis. Anterior transmural myocardial infarct caused aneurysm. It is a post-MI complication. 70-year-old patient had cough, fatigability, weight loss. He was diagnosed with squamous cell carcinoma on bronchoscopy. Resected specimen showed hilar lymph node of 1 cm which was showing black pigment. This black pigment is known as anthracotic pigment which contained carbon particles. Next case is 34-year-old female patient had migratory arthritis, pansystolic murmur, mitral regurgitation. Diagnosis is acute rheumatic fever which contains ash of bodies, T lymphocytes, plasma cells, plump activated macrophages. Anishko cells are seen here in acute rheumatic fever. Next case is 30-year-old male patient has fatigue, massive splenomegaly, hemoglobin is reduced, TLC is 1,50,000, neutrophil is 60%, blast is 6%, eosinophil is 4%, myeloid to erythroid ratio is 18:1. Diagnosis is CML. Chimeric BCR to ABL gene which showed reciprocal 922q34q11 translocation. There is presence of Philadelphia chromosome. So in CML all these features should be remembered. Investigation is FISH as well as PCR should be done. Leukocytosis which shows increased 1 lakh cells per millimeter cube. Blast less than 10% of circulating cells are seen in CML. Platelet counts are increased in CML. Next is a patient who had short stature, webbed neck, thick calves, shield-shaped chest, swelling of the angle, increased carrying angle, coarctation of aorta, bilateral small streak ovaries. All these are features of Turner syndrome. 45XO. Turner syndrome is due to complete or partial monosomy of X chromosome. Next is UV rays and arsenic causes skin cancer. Cigarette smoking causes bladder cancer. Arsenic, asbestos as well as beryllium presence with lung cancer. Occupational exposure with benzene. Patient had repeated infections, weight loss, easy fatigability, and evening rise in temperature. This is AML. Iron deficiency anemia is there is decreased transferrin saturation, decreased hemoglobin, hypochromia, poikilocytosis, microcytosis. Iron deficiency anemia there is increased RBC protoporphyrin, increased TIBC, increased ferritin soluble receptors. Glucose 6 phosphate dehydrogenase deficiency there is Hin's bodies and that is bite cells. Multiple myeloma, there is presence of flame cells as well as mode cells. Multiple myeloma, there is poor prognostic factor. Beta 2 microglobulin is present. Next is pap smear was taken which showed intact basement membrane, hyperchromatic nuclei, pleomorphism, irregular nuclear borders, low maturation index with hole thickness, increased nuclear cytoplasmic ratio, did not breach the basement membrane, increased mitotic figures. All these features tell us that there is dysplasia. Next is a case, a child with palpable blanching purpura had abdominal pain, pain in knee joint resulting from arthritis. On urine examination, it was showing hematuria as well as proteinuria. Diagnosis is Hinoch-Conlin purpura. This mainly presents in a child with 3 to 8 years of age. There is IgA deposition in the mesangial region. Next is a case, 18-year-old male patient has gum bleeding, fever for 2 months, pallor, hemoglobin was 3 gram per deciliter, that means hemoglobin is decreased. TLC is 1500 milliliter, platelet is reduced, macrocytes are present, reticulocyte count is 0.5, bone marrow shows fatty streaks, bone marrow shows absent megakaryocytes, there is no immature cells. Diagnosis is idiopathic acquired aplastic anemia. Next is most common type of mycosis fungoids is cutaneous T-cell lymphoma. Portrior microabscess is seen in mycosis fungoids. A software engineer has easy fatigability, history of sitting in front of computer for 12 to 14 hours. He has a lot of junk food with less fruits and vegetables. Hemoglobin is 9 gram per deciliter, that means hemoglobin is reduced. MCV is 120 picoliter, that means MCV is increased. Diagnosis is folic acid deficiency. Megaloblastic anemia is due to cobalamin deficiency or folic acid deficiency. But in this question, patient has less amount of fruits and vegetables. So, diagnosis is folic acid deficiency. Next question, 54-year-old person having fatigue, tiredness, cervical lymphadenopathy. TLC and DLC is normal. There is no immature cells. Lymph node biopsy shows diffuse effacement of lymph node cells with intended nucleus. There is prominent nucleolus which is atypical. CD10 and BCL2 are positive. Diagnosis is follicular lymphoma. There is 14 to 18 translocation. Centrocytes are present. Centroblasts are present here. Next question. 65-year-old female patient is diagnosed with pure red cell aplasia, mediastinal mass, superior vena cava syndrome. Patient is having dyspnea, chest pain, cough. Diagnosis is thymoma, mainly in the anterior mediastinum. Thymoma is associated with paraneoplastic syndrome like myasthenia gravis, pure cell aplasia. Next case is chronic alcoholic patient has increased abdominal girth. On examination, shifting dullness was present. Liver span is less than 7 cm. On histopathological evaluation, there is presence of intracytoplasmic eosinophilic inclusions in hepatocytes. Diagnosis is alcoholic hepatitis. Presence of intracytoplasmic eosinophilic inclusions in hepatocyte is known as intermediate filaments. There is ballooned hepatocytes present here. Mallory Denk or Mallory Hyrin bodies are seen in alcoholic hepatitis. Next case is about Huntington's chorea. Huntington's chorea is an autosomal dominant condition. There is CAG trinucleotide repeat more than 40. There is genetic anticipation in Huntington's chorea. Cognitive impairment is present. Atrophy of caudate and putamen with ox vacuoventriculomegaly is seen in Huntington's chorea. There is decreased acetylcholine which causes dementia. Decreased GABA and increased dopamine causes chorea. Huntington's chorea treatment is haloperidol and tetrabenazine. Here, the affected chromosome in Huntington's chorea is chromosome 4p. There is gain of functions, that is expansion mutation. Fragile X syndrome affects CGG repeats. Friedreich's ataxia affects GAA repeats. Myotonic dystrophy affects chromosome 19 in the CTG repeats. Myotonic dystrophy presents as muscle loss, cardiac arrhythmia, cataract, frontal balding. Marrow is hypercellular. Achalasia cardia, there will be decreased release of nitric oxide and VIP in the distal part of esophagus. Nitric oxide and VIP are secreted by inhibition of neurons of Auerbach's plexus in distal esophagus. Triad of achalasia cardia is incomplete relaxation of LES, that is lower esophageal sphincter. There is increased tone of LES and absent peristalsis. Papillary carcinoma of thyroid consists of orphan ani-nuclei, psammoma bodies, branching papillae with fibrovascular stalk. Next case is 23-year-old male patient has history of fatigue and tiredness. Hemoglobin is 9 gram percentage, that means hemoglobin is reduced. MCV is 101 picoliter. There is macrocytic RBC, hypersegmented neutrophils. Diagnosis is megaloblastic anemia seen in chronic alcoholics. There is deficiency of folic acid. Anionic antigen is subendothelial. Cationic antigen is subepithelial deposits. Neutral antigens are mesangial deposits. Next case is 50-year-old patient having retroperitoneal mass. Biopsy showed ground substance, branching capillaries and few immature adipocytes. Diagnosis is myxoid liposarcoma. Liposarcoma is the most common sarcoma in adults, which is seen in 5th to 6th decade of life. Liposarcoma affects the deep soft tissue of proximal extremities and in retroperitoneum. Next case is a large friable irregular vegetations on heart walls is seen in infective endocarditis. Embolization is present in septic arthritis as well as mycotic aneurysm at site of lodgement. Infective endocarditis affects aortic valve as well as mitral valve. Next is type 1 rapidly progressive glomerulonephritis is known as good Pasteur's disease. Here there is linear deposits of Ig and complement along with glomerular basement membrane. Antibodies are non-collagenous domain of alpha-3 chain of collagen 4 of glomerular basement membrane. Next is 55-year-old male patient having hematuria, pedal edema, no glycosuria, creatinine is 9. Microscopy showed crescents. Diagnosis is rapidly progressive glomerulonephritis. Here the investigation we should do is anti-glomerular basement membrane antibody testing. Post-infectious glomerulonephritis shows subepithelial humps. IgE nephropathy or Berger disease shows mesangial and paramesangial deposits. IgA nephropathy or Berger disease is also known as focal mesangial proliferative glomerulonephropathy. Membranous nephropathy shows subepithelial deposits. Focal segmental glomerulosclerosis shows effacement of podocyte as well as epithelial denudation. MPGN type 1 shows subepithelial deposits. MPGN2 shows intramembranous dense deposits. Next case is 3-year-old child has fever, rash, swelling on hand and feet, desquamative skin rash, edema of hand and feet, erythema of palms and soles. Conjunctival and oral erythema are seen. Cervical lymph node is present. Diagnosis is Kawasaki disease or mucocutaneous lymph node syndrome. Arthritis of medium to large sized vessels are seen here. There is thrombosis. Acute MI can be present, treated with intravenous immunoglobulin along with aspirin, which can reduce coronary artery disease. Next case is 5-year-old child with history of prolapsing rectal mass. There is painless rectal bleeding. Diagnosis is juvenile polyp. Histopathological evaluation shows cystically dilated crypts as well as glands. Sporadic juvenile polyp shows single mass as a retention polyp. Next case is 20-year-old patient has malabsorption. Chronic refractory anemia is present along with diarrhea as well as poor appetite. Duodenal biopsy showed crypt hyperplasia, increased intraepithelial T lymphocytes, villi flattening, villi atrophy, CD8 cells in lamina propria. Diagnosis is celiac disease. It is an autoimmune gluten-induced enteropathy. It affects HLA DQ2 and DQ8. Serological studies shows anti-endomysial anti-TG antibodies. Dermatitis herpetiformis is associated with celiac disease. Effacement of podocyte food process is seen in minimal change disease, which is also known as lipoid nephrosis. Effacement of podocyte food process is also seen in membranous nephropathy as well as focal segmental glomerulosclerosis. This minimal change disease, membranous nephropathy as well as focal segmental glomerulosclerosis, these all are podocytopathies. On electron microscopy, in all these conditions, we can see effacement of food process. Virtue triad is endothelial injury, stasis or turbulent flow, hypercoagulability of blood. Arterial thrombus shows white thrombi, venous thrombus shows red thrombi. Next is a case. Middle-aged female patient has thyroid swelling. There is increased TSH level plus increased thyroid peroxidase antibodies. On histopathological evaluation, there was presence of Hertel cells. Diagnosis is Hashimoto thyroiditis. Age group of the patient will be 45 to 65 years of age. Circulating autoantibodies against thyroglobulin and thyroid peroxidase is seen here. In Hashimoto thyroiditis, there is diffuse enlargement of thyroid gland with intact capsule. There will be atrophied thyroid follicles. Eosinophilic granular cytoplasm is present. There is oncocytic metaplasia seen in Hashimoto thyroiditis. Next case is 52-year-old male patient has nausea, abdominal pain, vomiting. Peripheral smear was showing macrocytes. There is hypersegmented neutrophils. On endoscopy, there was atrophic gastritis, which is associated with vitamin B12 deficiency. All these points are suggestive of pernicious anemia. Here in pernicious anemia, the autoantibodies are against the production or activity of intrinsic factor, which is required for the uptake of vitamin B12. Lab investigation of pernicious anemia includes serum B12 will be reduced, serum folic acid is normal, Schilling test is positive, methyl malonyl coenzyme A in urine is present, serum LDH is increased, neurological signs are present, achlorhydria present. Next case is 35-year-old female patient has a lump over the upper outer quadrant of breast. Histopathological evaluation showed mass showing cells in mucin poles which had faint nuclei. Diagnosis is colloid carcinoma or mucinous carcinoma of breast. It is an invasive breast carcinoma. In colloid carcinoma or mucinous carcinoma of breast, there is intracellular as well as extracellular mucin deposition. If it is intracellular mucin deposition, there will be signet ring appearance. Next is in lobular carcinoma of breast, we can see Indian file or single file pattern. In medullary carcinoma, there is anaplastic cells with lymphoplasmocytic infiltrate. Papillary carcinoma shows leaf-like arrangement of fibrovascular tissue. Premature aging in Werner syndrome is due to defect in DNA helicase, which is used for DNA replication as well as DNA repair. Werner syndrome or Bloom syndrome shows defective homologous repair. Defective DNA mismatch repair is seen in hereditary non-polyposis colorectal cancer, that is HNPCC. Hirschsprung's disease shows failure of migration of neural crus cells. There is devoid of Meissner plexus as well as Orbach plexus. Meissner plexus is submucosal plexus, Orbach plexus is myenteric plexus. So there is devoid of Meissner as well as Orbach plexus in Hirschsprung's disease. There is aganglionic segment present here, lack of coordination, peristaltic contraction and functional obstruction is seen here, which leads to dilation of proximal intestine to affected segment causing congenital megacolon. Biopsy of Hirschsprung's disease is like it shows absence of ganglion cells. Acquired megacolon is seen in Chagas disease due to loss of ganglion cells. Defective DNA nucleotide excision repair is seen in Xeroderma pigmentosa. Defective DNA base excision repair is seen in MUTYH associated polyposis. B cells produce IgE secreting plasma cells by interleukin 4. Lining epithelium of respiratory tract of middle-aged man of a chronic smoker shows change from columnar to stratified squamous epithelium. This is known as metaplasia. It is a reversible change. Next case is 24-year-old patient having swelling of the wrist joint. On histopathological evaluation, there was swelling, revealed spindle cells, palisading nuclei, verruco bodies. Verruco bodies, this is seen in schwannoma. Schwannoma, it shows a well-circumscribed encapsulated mass. Schwannoma inactivates mutations in NF2 gene on chromosome 22q12. Antony E as well as Antony B verruco bodies are present. Antony A consists of palisading of nuclei as well as spindle cells, which is known as verruco bodies. Graft in an identical twin is known as isograft. Isograft is present in genetically identical individuals. Xenograft is transfer of cells or organ or tissues in different species. Allograft means cells or tissues or organs in same species. Autograft means cells or organs or tissues within same person. All trans-retinoic acid is used as a treatment of tumor associated with PML-RARA fusion gene. For acute promyelocytic leukemia, we give treatment as all trans-retinoic acid. Next is about reperfused infarcts. Histology of reperfused myocardium shows eosinophilic contraction bands on light microscopy, which is like a closely packed sarcomere. There is irreversibly injured myocytes with damaged membranes when blood supply is restored for 12 to 24 hours after MI. Reperfused infarcts are hemorrhagic. It shows bleeding after flow is restored. A man was having 6 foot 5 inch height. He has early diastolic murmur, mitral valve prolapse of mitral regurgitation as well as aortic regurgitation. Diagnosis is Marfan syndrome. It is an autosomal dominant condition. In sarcoidosis, there is giant cell with cytoplasmic inclusions, non-caseating granuloma with fibroblastic proliferation at periphery. Next case is 12-year-old boy having 15 days of cough, weight loss and fever, cervical lymphadenopathy present. On lymphadenopathy biopsy, diagnosis was showing as TB. On histopathological evaluation, it was showing caseous necrosis. That means there was caseating granuloma, eosinophilic necrotic debris known as caseation, which shows collections of epithelioid cells as well as horseshoe-shaped Langhans giant cells as well as lymphocytes. All these features are suggestive of TB. Next case is 30-year-old male patient having chronic cough with sputum. Patient had dyspnea and wheezing and died of respiratory failure because of lobar pneumonia. Patient was a non-smoker. Patient was non-alcoholic. Lung at autopsy showed emphysematous damage involving enlargement of entire acinus, suggestive of pan-acinar emphysema or panglobular emphysema, which is due to alpha-1 antitrypsin deficiency. Most common emphysema is centri-acinar emphysema, which is seen in smokers. Paraseptal emphysema has increased risk of spontaneous pneumothorax.